So our next session is about mental health and digital developments, and I've got a brilliant panel with me, so I'm very excited. I have Professors Grainne McAlonan, Richard Dobson, Matthew Hotopf. They're going to talk to us about some of the advances that they're making in their area, but there'll be lots of time for questions. So again, using Slido, got the iPad, so bring those questions and keep them coming to me. I'm going to go to Grainne first. Would you like to introduce yourself and tell everybody about what you've been up to?
Sure, I'm Grainne McAlonan, and I'm a Professor of Translational Neuroscience, but I'm also a clinician in the National Autism and ADHD Service at the Maudsley Hospital. And I'm going to talk quite a lot about autism, but before I do that, I just caveat that autism is not a mental health condition, but it is a complex condition that affects brain development, can bring lots of strengths, but also can bring some difficulties for individuals. And among those can be a tendency to have mental health difficulties that cause distress, but also other neurodevelopmental features such as ADHD. So that makes complexity a major issue when we try to think about what are the brain mechanisms that are contributing to autism. And we really want to understand those because we want to understand what can we tell about prognosis. Most people want to know what will happen next, especially parents of children who have the condition. And we also want to understand if we can identify targets that might be intervened to help support individuals with autism. And we do that with the autism community because it's not for me to say what needs support. It's actually for the community to tell me what they want us to work on. So when we think about complexity in a condition like autism, we need to take a step back and figure out how to address it. And one of the principles behind our work is to think, well, complexity doesn't arise fully complex. And when we arrive in this world, we don't arrive with a set of social skills and language and thoughts that are complex. We actually have to build those skills up from much more foundational building blocks. And autism has its origins early in life, just when the building blocks of those more complex behaviours are happening. And the very first thing that has to happen in the brain is that our sensory systems have to develop. And when a child is born, it spends the first few years of life really having more and more sensory experiences that contribute to the more complex behaviours that child will have later in life. So that gives us an into slightly more simple, I use the word, very generously, but slightly more simple concepts that we can actually tackle and measure. And in our group across King's Health Partners, we've been collaborating with teams that image the very early brain around birth and even before, with King's College Hospital, with individuals who may have exposures that influence how the brain develops early on. And also we've been collaborating over a European network, which we lead, to look at things like sensory development. And what we've been finding, for example, is that very early on, in children who eventually go on to have a diagnosis of autism, there are some differences in the way sensory information is processed and the way sensory systems develop. One particular interesting thing we think is that a child who goes on to develop autism, for example, if that child is exposed to a series of repetitive sounds, normally you would expect the brain to start to ignore those sounds. But the child who goes on to have autism, their brain keeps responding. And what we've found is that seems to be linked to much more complex behaviours. So that sensory difference in suppressing information that they're receiving is linked to sleep disturbance. And sleep is a major issue for parents and individuals who have an autism spectrum condition. And it's also then linked to the diagnosis itself. So the idea is that potentially some fundamental sort of perturbation or alteration in the processing of sensory stimuli may actually have a knock-on effect on much more complex behaviours. And the reason that's important is when we move into adults, we've got something else to look at. And we think that sensory foundational aspect of the condition of autism, if it's really core to autism, we should find it in an adult. And indeed we do. Now that gives us a way to think, well, how do we regulate sensory processing, and might that help us think about interventions that might be useful? And what we find is adults with an autism spectrum condition also have that over-responsiveness to a repeated sound. But this time we've used a drug which targets the brain GABA system, which is like an inhibitory system in brain that dampens brain activity. And when we give that drug, just a single dose, to individuals, adult individuals who have an autism spectrum condition, we actually find that their brains begin to suppress the response to those repeated stimuli. The interesting thing is if we give that same drug to someone who hasn't got autism, actually they stop being able to suppress their responses. So we've got a completely different way to regulate sensory processing in people with and without the autism spectrum condition. We think that's super important because we can also measure the individual response to that drug. And so it means we have a way of saying individually, if someone makes a biological response to this drug, might that then predict a clinical response in a clinical trial? So we're hoping that that's bringing us much closer to a personalised medicine approach to the autism spectrum. Then, just because I think I have a bit more time, I'll expand out a little bit to link into what Richard will hopefully be talking about. And that's more that we're taking a much broader view of neurodevelopment and conditions like autism and ADHD in the work we're doing. And that's thanks to the information systems that we now have across King's Health Partners, including in King's College Hospital. And there we've been working with the liver team who look after these children with very rare, very early onset liver disorder. And those children are now surviving into adulthood, and there's been remarkable advances in medicine. But what's happening is the majority actually have educational difficulties and difficulties in the workplace. And to date, that's been, explained away because they miss school, because they're sick or whatever. But what the systems that Richard and colleagues have put in place, the IMPART system in particular, which allows us to screen for mental health difficulties and now for neurodevelopmental traits, we're finding that children who have that very early onset exposure do have difficulties that can't be explained away just because they've missed some school or because they were in hospital for a while. And that's allowing us now to say, well, actually, when this liver disease hits, that's also when these sensory systems are developing. So actually it makes sense. And we're following up these babies much more closely because we don't think it's fair that a child should just survive a physical illness without us appropriately supporting their brain health to ensure that they thrive going forward.
It's brilliant, Grainne, and the progress is immense. But Richard, for you, for the platforms you're developing, just the opportunity to build on this and also to work with the physical health trusts as well as the mental health trusts is amazing. Would you like to introduce yourself and set out some of your work?
Certainly, yes. So my name's Richard Dobson. I'm a professor of health informatics and based in the Department of Biostatistics and Health Informatics at the IoPPN. And so I guess, our focus is on data. We're living in the data era now, and we're producing huge amounts of data daily. And of course, there's a huge opportunity there, I think, with data to improve care. And that's at the core of KHP's strategy, to use data to improve research, education, and care. And so just one example of that is the data that we're collecting or is being collected through care across King's Health Partners constantly and through just routine care. And that includes the data collected into electronic health record systems. So you'll know when you're being seen at the hospital or when you're receiving care, then a lot of time is spent kind of logging that information, tracking and putting that information into systems. Historically, that would be paper-based, and but we've kind of evolved into electronic systems at least. But those electronic systems, in many ways, do mirror the paper systems that they replaced. So these things are huge and incredibly valuable in terms of the amount of data that's been amassed into these systems over the past 10, 15 years or so. And just at King's College Hospital, there's data on 1.5 million patients approximately collected over this period of time at South London and Maudsley, Mental Healthcare Trust. It's around 500,000. So it's huge amounts of information in those systems. But it's kind of a little bit one way at the moment. So as I say, they're not systems that have been used or developed in a way that allow easy analytics. They're kind of mirroring the paper-based system. So our opportunity, our challenge is to really turn that huge asset into something that we can use to improve care, improve and streamline services, and provide better education, provide better insights, and really put that data to use. Okay, because there's a big opportunity there to learn about you and the best treatment and best way of caring for you based on what's happened to other people and how similar you are to other people and the profile of those other people. So you need to use big data kind of analytics in order to kind of really get a handle on that data. One of the challenges is that, as you will know, doctors like to write. It's difficult to make medicine fit into a structured form. Okay, so people will want to write and they want to describe a patient in narrative. Of course, that's incredibly important that we have that capability. That makes it very difficult for us to be able to analyze that data because humans can read and understand information within text. Machines find it more difficult. So a large part of our work has been based around developing natural language processing techniques using AI. So these are systems that are able to machines that are able to read the records at scale, understand them, and put them into a format that can then be used by other machines downstream. So essentially kind of creating structure from the unstructured information that's in there. And of course, that then allows us to find out, generate insights from the record. And so we have systems such as CRIS and CogStack, which have been developed in partnership with between informaticians, data scientists, computer scientists, and the NHS, clinicians and IT teams within the trust. So it's been a real kind of collaborative, iterative process of co-development of these systems and then putting them into the trust. This gives us real-time access to the data. So we're able to understand, pick up early signs of safety events for people, adverse drug reactions, for example. We're able to understand our population as a whole. We're able to identify those that are being taken care of in serious mental illness services, able to understand the physical healthcare needs of those people and make sure that they're being addressed. And we're able to understand areas within our local community where there could be targets for intervention. So maybe a lot of people with psychosis are coming from a particular part of South London. We can then design an intervention around that. And we're producing dashboards to present this information to clinicians. So we're really kind of taking the data and putting it into the hands of the people that really need it and the people that are investing the time in putting the information into it. Because we need to kind of take people away from the screens that are a distraction from the care and make that data more easily accessible to direct them and less of a distraction around collection and put it to use for better care. And of course, the information that's within those systems is an incomplete picture. So we then want to augment that information with programs such as Imparts, which Grainne just mentioned, which means that we're additionally collecting information on depression, on well-being, on anxiety, whilst people are coming through physical healthcare conditions. So then we can kind of pick those things up and start to address them. We also want to make sure that the data that we're collecting on people is not hidden from people. So, the ability through programs such as My Healthy, we're taking some of the information that's collected and generated by people in services and then giving that information back to people through a portal that they can see, that they can access, and then also actually collecting additional information from them remotely to understand how they're progressing and how they're responding to treatment in that kind of remote ambulatory setting. And that information then comes back and is available to the care team as well. So it starts to take us away from this kind of periodic and kind of sporadic way of treating people and seeing people into something that's a little bit more continuous, a little bit more two-way, and starting to take information and take it out of the hands of or share it a little bit better with the people that are being cared for, and that helps with self-management as well as the care teams being able to manage. And then finally, we have the opportunity, I think, to really take advantage of the fact that everybody is carrying around a smartphone. Almost everybody, and many people have wearable devices, Fitbits and Garmin-type devices. And these are kind of potentially really informative in terms of health and mental health. So, we want to be able to think about how we can start to use those devices to augment the data even further, and that could lead to strategies that are a lot more preventative. We could potentially pick up people at risk, early diagnosis, as well as kind of understanding when and preempting relapses for people with diagnosed conditions, understanding and being able to monitor treatment response to medication. And we can start to collect data passively because these devices have embedded sensors, so it's kind of less burdensome on people, but also actively, so people recording and logging diaries, for example. And, so we're starting to look at combining this kind of low-level sensor that we get from these devices into informative kind of digital phenotypes of state. And, looking at speech, being able to track cognition, and using heart rate and using GPS whilst preserving privacy in order to kind of understand people's mobility patterns, using the phone to understand gait, and sociability through the kind of interactions that the phone is having, the way people are using the phone itself. So, to understand cognition in terms of, their responses to particular prompts and the kind of apps that they're using. And so that provides us, that kind of work is very much early days, but I think that provides us an opportunity to provide this more kind of rounded 360 care.
It's utterly fabulous. So, Matthew, this is over a decade of just intense innovation, hard work. Tell us a bit about yourself and what you've been doing.
Well, thanks. I'm Matthew Hotopf. I'm a psychiatrist. I direct the NIHR Biomedical Research Centre at the Maudsley, and I'm Vice Dean for Research at the Institute of Psychiatry, Psychology and Neuroscience. So, in a way, I collect very long job titles. But my interest, I've come from a background of epidemiology and psychiatry, but my clinical interest has been around physical health, the interface between mental and physical health. And in a way, what I want to do is build a little bit on what Richard and Grainne have been talking about, because I think if you think about mental health, we tend to kind of put mental health into a separate category. It goes, we often use the kind of analogy of Denmark Hill separating the Maudsley from King's College Hospital, and these being very separate entities. But the reality, all the epidemiology tells us this, the reality is the two are hugely interlinked, and you can't provide great physical health without understanding how your patients are actually responding to their condition. You can't provide good mental health without attending to the physical health needs, because our patients, people with schizophrenia or bipolar disorder, die 15 to 20 years earlier than they should, and that's not suicide. I mean, suicide happens, but it's not the main cause of that increased excess mortality. So there's a real urgent need of kind of integration. And then if you think about mental health more broadly, it has huge impacts in terms of every aspect of someone's life, in terms of wider societal impacts. So children with mental health disorders, their education suffers. In fact, if you look at people who are not attending school, the kids with cystic fibrosis, they have episodes and they get back to school, but the kids with significant mental health problems don't, and they lose out on education. If you think about occupational function, people who have mental disorders have real struggles in staying in the workforce. The people with the longest periods of time out of the workforce because of ill health have mental disorders. And so it continues. So it has this sort of massive societal impact. So you can't just see this as a kind of isolated entity. So the informatics comes in and is so exciting. We're so interested in data and digital because of the opportunities it provides one to be able to start integrating better. And it's writ large in our strategy, and it's hugely important in terms of thinking about how care will be delivered in the future. So what Richard and Grainne have been talking about are different ways in which data can be used from the level of public health. So we've done a lot of work trying to actually contextualize mental health by bringing in other data sources. So, for example, linking our mental health records with educational records, which means that you can actually then see where there are secondary schools with high rates of self-harm, or what are the hotspots in terms of where the need lies in our local area. You can also then track educational outcomes according to different types of disorder. And other colleagues, I mean, this is work which has been done by many different people. Johnny Downs in child psychiatry, my colleague Sharon Stevelink linking benefits data, so actually going and knocking on the door of DWP and getting benefits data linked to our health records. And it's the first time that's been done for both those instances, the first time it's been done, and huge kind of struggles to get that to happen, but potentially it unlocks a whole load of different understandings. So at public health level, really important. And then at the level of delivery of care, obviously, you want to be able to put surface information to clinicians, which is buried. And unfortunately, our health record systems are not particularly intuitive. They are typically systems where there's, the emphasis is putting data in, and they're not very good at putting data out. And I often say that if Amazon or John Lewis were using these systems as their front end, they'd be out of business because they're not great. I think that's going to improve, and we've got Epic coming. That's going to make huge differences, hopefully, in terms of the sort of analytics which are available. But a lot of what we've been doing in SLAM has been trying to surface information for clinicians and clinical teams about what things they could be doing which would actually improve patient care. So identifying people who have had multiple different episodes on different antipsychotics but haven't had, in a sense, the gold standard antipsychotic if you've got treatment resistance, which is clozapine, and how do you get that to happen more quickly? And you need data to be able to do that, and it's non-trivial in terms of actually making our systems answer those questions. And then at the level of personalization, I mean, Richard and I have been working on a big program called Radar CNS, which has taken up a lot of our time in the last 6 years, but is about this use of smartphones and wearables, because in a way, the opportunity of smartphones and wearables is that you've got a whole range of different behaviors, higher cognitive functions and behaviors, which become measurable and accessible to us in a way which in the past you'd have to have people very intensively studied for short bursts, which meant it was unscalable. So the classic neuropsychology assessment, you're talking 2 or 3 hours with a highly trained neuropsychologist, whereas actually you can get it's different information, but you can get a lot of information which is relevant from the use of a smartphone. And similarly, sleep. A wearable can tell you things about sleep. It's not gold standard sleep lab, but it is telling you a lot of things which have insights, and it's inherently scalable. So we've developed algorithms which can start actually predicting the onset of a depressive episode in someone with recurrent depression. Not at all, not perfect by any means, but it means that you can start having a prompt which can build health systems to become more responsive. And then I suppose the next layer is how patients interact with the health system. And this is absolutely crucial, I think. So the Imparts program, which we've been running through KHP for 10 years or more, has been about trying to get patient-reported outcomes routine into practice, but then actually also providing support and instructions for the clinicians to be able to use that information. And finally, as a sort of another layer, is actually interventions and being able to help people using digital interventions, not as a replacement for standard care, but as a way of making care more widely available. We've got huge problems of waiting lists, huge problems of people not able to access care and treatment. And there are many things which digital therapeutics can actually offer, which would enhance care and provide options for earlier care. The last thing I want to say is that in order to get this right, you have to have a whole load of different things in place, and in a way, you need KHP as a vehicle to do that because it comes down to things like leadership. Organisations have traditionally been very cautious about the use of data. These things are, as I say, non-trivial. It's actually really, really challenging getting a healthcare system, health records being used effectively to improve clinical care. And so you need to bring the right people together and have very strong leadership. I'm going to stop, but I think that sort of theme about I think there's one other thing I should say, which is that you have to bring our citizens and patients with us. And this is absolutely crucial. So the work we've done with CRIS, which is the system within SLAM, has always had a patient-led governance. And within Radar, when we're using these devices and tracking people's GPS, you have to have patients buying into the idea, or research participants buying into this and seeing the benefits and trusting. And I think it is because we are a university and NHS trusts, people do trust that in a way which actually other organisations are not, don't automatically gain the same trust. It's very, very precious.
Yeah, I think that's absolutely right, Matthew. And so one of the themes of today is about reducing health inequalities, and what you've all talked about is the opportunity for digital and technology to ensure that those groups that have previously been excluded or have felt excluded are more drawn into their health and aware and see their own data about their health. What are the opportunities for drawing in those groups more, do you think? I don't know whether Richard wants to pick up on that.
Well, I think we've been looking in the wearable space. We've been really kind of looking to see how people are engaging with this kind of work, and so making sure that right from the outset that it is co-designed and co-developed with participants, such that you're not putting devices or asking people to put devices on that they don't want to wear. And that's a very kind of basic thing. But we're finding that actually making sure that you recruit a representative cohort is one thing, but then understanding which groups over time kind of start to disengage with the process. And there are clear patterns that, there are certain groups that it's more difficult to engage with the study longitudinally over time, and you get dropout from certain groups. So I think mHealth provides, or mobile health and these devices provides the opportunity to reduce some of the inequalities. But actually, there's still work to do, and actually it just highlights specific areas and specific groups that require further targeting. So with the mobile health work in depression, we know that there are certain groups that will require certain changes to be made to continually engage them with the work.
I mean, if I could come in, I think one of the challenges is, the digital space allows you to identify the health inequalities. And actually, it's incredibly important, this, and it's a reason why having health records unlocked for research purposes is so important, because the people who get into most traditional medical studies, there's a huge bias towards people who are white, higher educated, etc., etc. So in a way, you're always losing the groups of people who we know in the population you're most interested in terms of focusing services and support. So the digital space allows us to identify that. There's some work being done in Lambeth DataNet, which is the sort of pooled resource of all the GP records, and it's absolutely eye-watering, the health disparity in terms. If you take an outcome like multimorbidity, which is having more than 2 or 3 long-term health conditions, There is absolutely eye-watering differences according to ethnicity. People from Black Caribbean, Black African, who identify in those ethnic groups, have 3 times the prevalence of multimorbidity, and any response to that has to take account of that. Now, I think that the challenges are quite significant in terms of how one actually engages people, builds trust, because typically when you introduce a new technology, it actually exacerbates health inequalities. So you might expect mobile health, the people who use these sorts of technologies tend to be, again, people who are white, people who are highly educated, people who are interested in their health, etc., etc. So how do you actually bridge that? When we've done quite a bit of work trying to actually build a race and ethnicity advisory group within our BRC, which has now 70 members, very engaged, and thinking about this right from the get-go in terms of research studies and how not just the communication with participants, but also how you might unwittingly actually disenfranchise certain groups in the way in which you do a study. I think this is crucial.
I think that's absolutely right. So I've got a question for Grainne from Joseph Casey about making sure that digital doesn't overtake the opportunity for face-to-face therapeutic intervention. And then I've got a question from Julie for Richard about One London, how London might build on this and work together. But just the question from Joseph Casey, Grainne, the real opportunity to advance digital technology, but people listening might think, oh, I'm just going to get wired up to something. I'm not going to have that opportunity to see Grainne or to see Matthew, and I'm not going to have that opportunity to face therapy. How are you kind of making sure that we run the two together?
We have to, because what generates the data that we collect digitally comes from brain.
Yes.
And so therefore, ultimately, you've got to look at brain, you've got to be engaged with the individual, particularly in complex conditions, to understand what they're experiencing. And in terms of more neuroscience research, you've got to actually figure out, what do I need to be testing? What might I need to shift that will have a knock-on effect on the everyday experiences that they can then be accessed by digital technology. So I think we've got a great opportunity to both have very in-depth assessment of an individual and understand very carefully how their biology relates to these more kind of surface level measures. But we can't have one without the other.
Absolutely.
So, and I think this is the strength of KHP, is that we are able to do the in-depth research and engage very much person to person with individuals, and then think about how might we scale that up so that people with similar difficulties, and that's transdiagnostic often, can access the digital world that we can hopefully provide for them.
And see their own data as well. So Richard, the advances are incredible, and much of the work at the IoPPN and SLAM has been the basis for this and the platform for this, and the progress is superb. We're working as One London. We're working as Pan London, so 5 ICSs, 3 HSCs, all the universities of London working together to think about the digital integration for London. What are the opportunities from that London joint working, do you think?
Well, I guess the opportunities are that we will have a much greater, better view of patients. We are very kind of, although we have some linkages at the moment, we only have kind of this kind of single view usually of a person and the care that they're receiving. So sometimes we might have linkages to the primary care record, but obviously people are moving around, people are being seen across different services over different periods of time. So to have One London as an initiative connecting up, firstly, having these ICSs in the integrated care systems in the first place is a great thing, which gives us much greater view of data at scale. So we're much more able to think about the rare conditions, for example. But when we're able to view the data at this scale. And so, these integrated care systems and then the combination of these integrated care systems provides, an incredible opportunity to be able to think about the care of an individual, not just from one service, but across services. And of course, the integration of the mental with the physical health care.
Is the holy grail
it's
of
the
all
holy
of
grail,
this.
yeah.
So we've got a question from somebody who's anonymous, so I don't know who's asked it, but thoughtful about you talking earlier about patient information and being shared back with patients through the portal. What's the opportunity to connect down the line with the NHS app? The NHS app has developed hugely through COVID. Are we able to talk with each other through the NHS app, do you think?
Yeah, I think so, over time. I'm hoping that that's going to provide the kind of mechanism through which we can start to kind of link information from wearables and devices with the kind of electronic health records,
yes.
Using the kind of NHS login and using people's NHS IDs in order to kind of enable that.
Yeah, I think that's absolutely fantastic. And lots of questions in the chat, Matthew, just about trust. And how we, as we talk about wearables, as we talk about sharing big data, starting to flag risk, anticipatory care, but how do citizens build that trust and good thought about what we're doing and how we take them on that journey? You mentioned some of the user involvement that you have.
Yeah, well, I think you need to be constantly vigilant and have the dialogue. So when we set up the clinical record interactive search CRIS system in SLAM, this was more or less a first of being able to use a whole hospital's health data for research purposes, de-identified, all that. It was very innovative at that point in time, and there was a real fear. And you have the care.data kind of debacle where the idea of using primary care records nationally was scotched because of concerns about the data were going to be sold, it was going to be used for all sorts of nefarious purposes, etc., etc. But when you brought patients, service users into the room and started asking them about this, to some extent they were quite surprised about what we couldn't do, and most people wanted their data to be used in a way and expected us to be able to get the insights and be able to spot problems. And I think that that's why the dialogue's important, and you have to have certain checks and balances. So, the then chief executive basically wanted to ensure that anyone using the system who misused it could be sacked. I mean, that was a kind of basic that you would make it very clear to those using the system there were certain expectations. The data governance was incredibly important. It was a security model. Things stayed within the NHS firewall. Data were de-identified. We let people know that this was being done with their data and they could opt out if they wanted to, etc., etc. And I don't think, I think in the 15 years the system's been running, I don't think there's been, anything which has set alarm bells ringing. And over that time, increasingly sophisticated record linkages and the use of NLP and so on to build new insights. The interesting thing with the wearables work, which Rich and I were involved in Radar, the assumption was that people were going to find privacy really challenging and really, really worried about privacy, and we were using GPS. But of course, your phone company's got your GPS data. There are all sorts of other entities which have that data, and people actually weren't that bothered by that. We obfuscate the detail anyway. But what they were bothered about was, is the data going to be used in a way which is helpful to my health, and are you going to come up with reliable insights? Because I don't want to have something which means that I'm being called up all the time for a problem which doesn't exist, and certainly certainly anyone in the health system doesn't want that. You don't want a high false alarm rate or something like that. They want to know that the data actually are of some value. But it was a totally different discourse from what the ethics committee might assume that it was going to be.
So listening to patients all of the time is going to be important. The fourth theme of the KHP 5-year plan is about workforce innovation and transformation and preparing the workforce for the future. And Dr. Andrew Parson, who's a GP lead in Bromley, asks how some of the learning from all of this development might build some of the training and education for the workforce of the future. I don't know if Grainne wants to comment about how that might be in ASD, for instance.
I think there are opportunities to unleash us from the silos that we're in. So in the past, there's been a tendency to think of mental health as very strictly one disorder or another, and to forget about neurodiversity in the context of that and how a mental health condition might present itself in individuals who are neurodiverse. It makes life difficult because it feels like everybody could be a little bit of everything, but that's the reality. If someone has a mental health condition that we would have called depression, they also potentially have anxiety problems. If the stress of living with a neurodevelopmental condition such as ADHD or autism is driving some of the self-esteem and low self-confidence that might be then pushing depression, we need to understand how those symptoms all link up. So for training, we need to stop thinking that, oh, I've got to train this person what depression is and what anxiety is or what psychosis is, and not think about how they're actually interrelated. And our patients are really interesting to study, I think, and they want us to help understand the relationship of their different symptoms, because we have got an opportunity, because symptoms are linked, if we can perhaps make a difference to one aspect of that, again, there can be knock-on effects that improve, hopefully, overall quality of life. So training does have to change, and it will be hard to, I think, shift what has been a very traditional kind of approach to medical and psychiatric training and healthcare delivery. But that is something that still has to be tackled. Problems are transdiagnostic, and if we want to scale up the impact we can have on most people, we have to acknowledge that and make people think, actually, it's not just this one thing I'm looking at. If it's a physical condition, I need to be thinking how their brain health or mental health is at the same time. And then I'll be much more satisfied, because hopefully people will feel better.
We'll be able to do that. So I'm going to ask Matthew about how imparts might have helped staff learn more about mind and body and the other sides of the road. And then I was going to come to Richard about multidisciplinary working. And a clinician said to me recently, we're just employing mathematicians and computational scientists. So the wider team is now much more interesting, isn't it, and who we're bringing into our workforce. But Matthew, 10, 12 years of imparts, educating people across rheumatology, diabetology, respiratory, about aspects of mental ill health and how to care and screen and treat.
Yeah, no, absolutely. I mean, imparts is a platform really to help any service which deals with long-term medical conditions and has patient cohorts. And the reason for that is, if you look at any by any outcome, whether it's quality of life, health economics, mortality, adherence, etc., if you have a mental disorder, you're more likely to do less well for those disease-specific outcomes as well as overall. So imparts does this job of trying to get the information off the patient, and it's not just about mental health, it's about mental and physical health. So you're getting patient-reported outcomes, which you want to try and routinize. You want to make this part of the norm, because we're very good at tracking biomarkers of disease severity, but we're much less good at actually asking patients how they're feeling. But a big part of the imparts program has been to try and provide training and support for clinical staff across a whole range of different disciplines. So we try and be as inclusive as possible about how they might want to address certain mental health conditions, and so we've been very flexible in the way that's offered. We have psychologists who will go to a clinical team and offer training which is sort of bespoke to what that team identifies as what they need. And then we also developed a 5-day course, which is a much more sort of intensive experience, where people get in the room, and it's very problem orientated, and we use a lot of kind of actors and put people in real life situations and build on their experience. And the other bit of the imparts has been a MOOC, a massive online open course, which is
huge.
3 weeks of learning, and anyone can sign up. It's it gets good ratings.
Pretty fabulous. But Richard, we all need to be mathematicians and computational scientists.
Yeah, I think data literacy has to be a core component of all education where it isn't already. We're obviously running MSc programs, which we run in a very kind of flexible way. We have a series of short courses as well. We have an online training program which is specifically targeted towards people already, healthcare workers. We have centres of doctoral training for people that want to work in data science, and Matthew has one, I think, specifically targeting healthcare professionals. But the way that we work is in a very collaborative way. So we as a group are not computer scientists or data scientists sitting in a room by ourselves. We're very embedded and we're very collaborative and very dependent on partnerships with care teams and clinicians and the trusts and people within the trust, because that's the only way that we work on something which is relevant. And so we work with some incredibly smart clinicians who are incredibly data savvy, and our work is very much kind of done in collaboration with them. And we initially we worked in isolation, and we were trying to push things that just weren't. We thought they were interesting, but they're not. They're kind of missing the mark in terms of things that we should be really targeting. And of course, we want to develop things which generate impact. So all of our successes have been based around collaborative working, where we have clinicians in software development meetings, and we have software developers going and spending time on board rounds and kind of sitting in MDT meetings and things like that. So it completely has to be there has to be complete fusion.
It's fantastic. So this has been a brilliant conversation. So the brain is going to reveal itself over the next decade, particularly with Grainne at the helm, the building of trust, looking at good governance, listening to patients and giving patients their data and being in partnership with us on their data, and then building joint teams that are able to look at this and work on this together. But we've got a great question from Paul Guillory about just the complexity of scale up. This is a lot to do. How do we scale up? But also, what's your expectation of the next 5 to 10 years of how the brain's going to reveal itself and the work that's ahead of us? That's like a Nobel Prize winning answer is required. But in autism spectrum disorder, what's your hope for the next 5 or so years, Grainne?
Well, I really believe we can have traction if we try and simplify how we look at how the brain develops. And we are finding buy-in from industry, because industry had left the space of really investing in targets that we would feel are important. But what we can do now in terms of, say, the sensory stuff I spoke about is we have a way to actually look back at what we can learn from, say, animal neuroscience, where there's incredible ability to have fine resolution of what happens in brain, but we need to be able to take that information and ask, is it relevant in the human brain? And now we can do that because we're starting to understand the kind of mechanisms we should be targeting. Yeah. We should be testing with existing drugs what mechanisms might be involved in something that becomes an important symptom that gives an individual difficulty that they want addressing. And so we've had investment from different industries now, including from Compass Pathways, for example, and we're using psilocybin to test what might be different about the way the serotonin system impacts in sensory processing in autism, and hopefully we'll take another target to target another brain chemical system and find out more about actual living human brains and how they work, and then translate that work at scale through digital technologies into something that helps the population. That's brilliant. So we're out of time. It's been a fantastic conversation. Watch this space, I think I would say. It was a brilliant segue into the 7 videos in 7 that we have coming up, and they're going to be all about commercial partnerships. But thank you to Grainne, Richard and Matthew. Thank you so much.